I've put together a talk on management of ankle fractures in the elderly. And the reason they do badly is because most of them have some degree of osteoporosis or osteopenia. And in the UK, we've almost reached epidemic levels with 2.5 million women in UK have some degree of osteoporosis. That equates to about 50 times or 50% increase in fracture of a bone at some point in their life. So some home truths about bone biology. Peak bone mass actually forms during the adolescent years and teenage years. So it's very important to actually tell children and young people to play sport, because the bone you build by the age of 20 is the bone mass you live with for the rest of your life. And in the middle age, the cortical bone is resubstituted to equal amounts. So you're in equity. But the moment you start to become old, which is beyond the age of 45, 50, especially in women, the estrogen levels drop and the androgen levels start to drop in men. And that's when cortical bone loss happens in later years. Now, we've heard a wonderful talk with Dr. Jha about medication for osteoporosis and osteoarthritis. I think at the end of the day, in the long term, tablets and novel therapies like targeting the immune system is where we are going to win. So anyway, osteoporosis was badly treated, but I think now in the UK, we've got a handle on it. Every hospital has a nurse, an osteoporotic nurse, and we do bone protection for most patients. And in our experience, it requires an MDT approach. You need to have GPs, doctors, orthopedic surgeons, physicians, and nursing staff thinking about it. And you can predict fractures in the future, and a lot of them can be prevented. So what are the risk factors? Increasing age, female sex, Caucasian and Asian, sedentary lifestyle. So I think we need to move towards getting older people much more active. And then you have multiple births, excessive use of alcohol, and tobacco use. So if you do decide to treat this condition, fractures because of osteoporosis, you need to treat osteoporosis as well. So I think it's duty bound to look at lifestyle changes, better nutrition, more exercise, fall prevention, stopping smoking and alcohol. If you do look for secondary causes, are they rheumatoid arthritis, GI problems, bone issues? Are they on any medication which causes osteoporosis? And finally, I won't cover drugs much, but generally what we use is these kind of drugs, which our orthogeriatricians help us, to do the drugs therapy. Now, coming to the topic, ankle fractures in the elderly, is osteoporosis the culprit? Is it easy to just blame osteoporosis for fracture? It appears it's not the case, because when you look at big studies, Seeley in '96 looked at 9,704 women over age of 65. And when he looked at ankle fractures, most of them were overweight and they've had previous falls and they were reasonably active. And Greenfield in 2001 looked at 103 women aged 50 to 80 with ankle fractures and compared 375 age matched without fracture. And what came through was most of the people having ankle fractures in the elderly were very big and had a higher body mass index. So, that seems to be coming through with ankle fractures. Now, the next debate is plaster versus operations, and what are the problems? We do know if we put elderly into plaster for prolonged time, there's mobility issues, there's malunion and deformities, and there's chronic pain. So let's look at a few studies to see where we are. In the 80s and up to about 2011, we had a number of studies which showed patient satisfaction was better with open reduction internal fixation. The functional recovery was better with fractures being treated with an operation. And then in 2011, Oxford started a study called the Ankle Injury Management Trial for over 60s. And this was in 24 different hospitals with 625 patients, and it was randomized and prospective to close contact plaster or an open reduction internal fixation. There was a 6 months review. There was an ankle score, quality of life, range of movements, infection, malunion, and non-union. What we found was 19% of the patients who were in the cast treatment had to be aborted in terms of going to an open reduction internal fixation because they had lost position of the fracture. Secondly, open reduction internal fixation produced about 10% infection rates, and there was some degree of malunion in close contact plasters up to 15%. But if you ignore all these, the two groups did equally in terms of range of movement, pain management, and quality of life issues. So if you get it right in choosing the correct patient for the correct operation, it appears that the results are equally good. Now, if you decide to do an open reduction internal fixation, I would classify as the old options where you had wires, rush nails, standard plates, and then combination techniques. But the newer options now in 2022 would be locking plates, fibular nails, hindfoot nails, and a combination of others. So the difference is the locking plate has no toggle effect. It's got a spike effect, and the angle is fixed onto the plate compared to the conventional plate. And there's enough studies on the locking plate to show that there's a higher torque to failure and maximum torque to failure. And if you put a posterior lateral plate as well, that actually stiffens the fracture construct as well. So as long back as 90s, people started to look at porotic bones to see how you can stiffen the fracture. Gawhale and his group used the hook plate, and then they used the posterior lateral plate along with a K-wire, and they showed that there was a 30% increase in stiffness of fractures. Subsequently, over the last 5-10 years, we've been using all modern technique with the elderly. Now, this is one of the common fracture patterns in the elderly. Usually you get very low fractures. And so if you use the normal plate, I suggest that this would not work. So you have to use a locking plate with a number of screws lower down, and then stiffen the whole construct with syndesmotic screws to try and get a very good result. And what happens is you can actually mobilize these people much earlier than in a plaster or in a conventional treatment. Now, multiple syndesmotic fixation has been a technique which we've used for quite some time now, and a lot of literature has been produced. What it does is it significantly stiffens the fracture construct to resist axial and external rotation loads. So you get a very good fix on the fracture, which you wouldn't otherwise get because of soft bones. So here's a patient again with a very low fracture, syndesmotic screws, and a plate on the outside and an ankle which looks very good. Next, the fibular nail. The Edinburgh group came out with a fibular nail, and they ran a prospective study or functional outcome study on it and showed they had very low rate of infections and you could mobilize very early. So what's the advantage of the fibular nail? Even though the swelling is very big, you can, through a very small cut, thread the fibular nail. It also has a syndesmotic locking possibility. And so with a very small cut, you can actually stabilize the ankle. But what are the disadvantages of this fibular nail? It's fiddly to use. If you have fractures which are very soft, you can actually explode the fibula. And if you have a fracture pattern which is the unusual pattern, then you find the entry point is extremely difficult. And lastly, a tibial intramedullary nail. Now, this is a very good operation for the elderly because it's a quick operation and it gets the patients up and about and walking very quickly. And this can be done for very severe fractures like this, distal tibia going into the ankle. You can just thread a nail and within 2 days, you can actually at least sit them out and get them up. And once the wound heals, you can actually mobilize them. So these are in principles what I would do for an ankle fracture in the elderly. And my summary would be, this is a difficult problem. You have to think of modern ways of fixing this if you decide to fix it. You can treat it in a close contact plaster, but be aware you have to follow the patient every week and change the plaster. And a good 20% of them move on to having an open reduction internal fixation. You need to protect the fracture with plasters once you fix them, and beware of pitfalls, because if you do not get a strong fix, the fracture will fail. Thank you very much.